It's so good to see everybody. I really enjoy spending time with the Elnick family, and just want to say thank you to Rose and Kelly and everybody at Elnick for organizing this. So just hello to all of you, and you're very welcome here. And feel free to engage in the chat. Feel free to put questions there that we can get to on the other side of this presentation. I'll try to keep it as brief as possible, but like my mom says, I can talk the paint off a wall, so I'll try to limit it. I start almost every presentation in palliative care with this quote. It's one of my favorite quotes from an Indigenous Australian artist and activist and advocate named Lilla Watson. And she said, "If you've come to help me, you are wasting your time. But if you've come because your liberation is bound up with mine, then let us work together." And I really think that that quote speaks to the ethic, the underlying ethic of palliative care, of oncology nursing, the idea that we really are invested not only as professionals, as nurses, we're not simply looking to fix or help, but that we're really looking to be of service, that we really recognize a shared humanity in this healing work that we do. And I think that's so important, especially during this time of COVID. And so I want to talk about the changing nature of palliative nursing and oncology, where we've been this last year, a path forward. I'll talk about some of the Elnick initiatives, some of my own initiatives during this time in my research, but hopefully just create a space for reflection and dialogue. My Twitter handle is down there at the bottom at brosa_PhD. Please do follow me. Please do follow Elnick. We consistently both post wonderful resources and articles, etc. And so just a few acknowledgements for today. I want to acknowledge my T32, which is funded by the National Cancer Institute, my postdoctoral grant from the RWJF that supports my research, the Fellows of the American Association of Nurse Practitioners, which funded some of the research findings I'll share with you today. And I have no other formal relationships to disclose. Wish I was more interesting. I would be remiss if I didn't take a moment to just pause and invite into this space in remembrance all of our dear colleagues who we have lost this year during the pandemic in the line of service. And so some of the objectives for today, to reflect on how moral suffering has showed up in our practice environments. I know this was a big dialogue at AHPM this year. It's in the current issue of AHPM Quarterly, a constant dialogue in nursing to discuss relevant research on moral distress and some implications for palliative care clinicians and oncology clinicians, to identify some tools to address moral resilience and moral courage. And if I could just ask you all to please mute. I'm getting a little feedback on my end that's coming through quite loudly. And finally, to use advocacy as a method for improved self-efficacy in our fields, and of course for palliative care integration throughout the oncology context. And so I just updated this slide a few minutes ago, actually at 1:22 p.m. Eastern Standard Time. So this is where we are with the pandemic globally. This is from the Hopkins Center for Engineering. And so we see over 178 million cases of COVID on the upper right globally. The US all the way on the left is leading in terms of the number of cases and the number of deaths. The neon green, we see over 2 billion vaccines have been delivered. And on the upper right, I think I misspoke before, on the upper right, we see the daily number of cases that are happening alongside the total vaccine doses that have been given. So hopefully what we're seeing in the middle there is the daily deaths is a decline in overall incidence of COVID, as well as the mortality related to COVID as we increase vaccination. And hopefully this will translate into decreased suffering among not only society, but also among our nurses and the health workforce. So if you've been working clinically during all this time, nursing has really been at the center of the conversation. Many of us have been at the front line as clinicians. We've been bearing witness to suffering in patients' most vulnerable moments and in the distress of caregivers. Many of us have served as the surveillance systems of hospitals, of communities, and we've been trying to support each other as best as possible throughout the pandemic. Many of us probably shouldering moral injury, moral distress, and our own suffering as a part of that. So this is a painting by Van Gogh called Worn Out. He painted in 1882, and I invite you to just reflect on it for a moment. And I'm going to read you a poem by Mary Oliver. And when I read this poem, I looked up the painting and just had my own reflection and own insight for a moment. So the poem is called August by Mary Oliver. She writes, "Our neighbor, tall and blonde and vigorous, the mother of many children, is sick. We did not know she was sick, but she has come to the fence walking like a woman who is balancing a sword inside of her body. And besides that, her long hair is gone. It's short, suddenly gray. I don't recognize her. It even occurs to me that it might be her mother, but it is her own laughter-edged voice that we've heard over the hedges for years. All summer, the children, grown now, some of them with children of their own, come to visit. They all smile. Their father smiles too. A carpenter is hired, a roof repaired, a porch rebuilt. Everything that can be fixed. June, July, August. Every day we hear their laughter. I think of the painting by Van Gogh, the man in the chair. Everything wrong and nowhere to go. His hands over his eyes. In so many ways, this painting resonates with me, and I'm sure with many of you, because over the past year we've seen, maybe we see this painting in ourselves, maybe we see it in our colleagues, but many of us are feeling quite worn out as well. And in the social narrative, but also in the empirical literature, there has been an increased emphasis on discussing the well-being of the workforce. It has been such a huge theme of this past year. PTSD, burnout, mass bereavement, professional loss, moral injury, moral distress. And so more and more I'm hearing from colleagues about the vulnerable state of the nursing workforce and how we need increased efforts to really focus on health and well-being. And so during this crisis, this is actually from fixmoralinjury.org and their white paper on moral injury. They reminded us that burnout's been underway for decades, but of course the pandemic has really exacerbated it. And so they said that doctors and nurses die by suicide at twice the rate of their age-matched peers, that 2/3 of doctors and nurses express feeling more distressed during the pandemic, which of course is understandable, and that about 2/3 of nurses say they may leave patient care earlier than expected, earlier than retirement. About 50% of doctors say the same. And so this is really interesting. We've seen certain parts of the world, like in Quebec, for instance, there's been a turnover of over 4,000 nurses leaving their posts over the last year, mostly due to burnout and other reasons. And so when we think of moral distress, moral suffering, we can look to the National Academy's report on taking action against clinician burnout that was released in 2019. And they identified moral distress as a work system factor that really influenced individuals and effectively influenced the outcomes on the trajectory of, on the spectrum between clinician burnout and professional well-being. And so this whole concept of moral distress was identified in the 80s by Jamieson, and he described it as the mental and moral repercussions experienced by nurses that prevented them from providing the proper care, usually due to institutional constraints. And interestingly, although the NAM report addressed burnout and system-level interventions for burnout, they did not provide system-level interventions for moral distress. And so the main difference there being that moral distress is something that's encountered by individuals, whereas burnout is really considered an occupational phenomenon related to work environment. And so this is another image from fixmoralinjury.org and their white paper. And so what tends to happen in a lot of conversations about burnout is we talk about work stressors and the double binds of loyalty to organizations. And if you follow the dotted line, most people in the literature and most dialogues from leadership go right to burnout. Well, there's stressors and there's burnout. And the piece that we really tend to miss that has become so incredibly important during COVID is this whole realm of moral suffering, moral distress that leads to an accumulation of what we call moral residue over time, and ultimately moral injury, which is described as the wearing away of the deepest fibers of our ethical integrity. And so when we talk about how we're going to move through this, not only coming out of the pandemic in one piece, but how we're going to sustain each other as human beings, as nurses working in oncology, working in palliative care. It's really this integral part of moral suffering that we're going to have to take a look at. And one of the narratives that I've been very interested in this year, of course, as a nation, as we are continuing to reckon with racial inequities, with longstanding historical injustices due to race and systemic marginalization for a number of communities, BIPOC communities, LGBTQ communities, I've really come to focus on this idea that social injustice is ultimately moral distress. And the reason for that is that when we work within systems that operate within a systemic marginalizing way, we are unable to uphold the standards of nursing. We're unable to uphold the ethical standards of healthcare. And this creates distress for us for being unable to alleviate suffering and to also bear witness to disparities that continue to affect the outcomes that we are capable of influencing. And this has left many of us feeling lost, quite literally on a journey trying to find our way. And of course, the pandemic has complicated this. So in that sense, I'm going to kind of pivot a little bit and share some of the research that's come out this year about moral distress. This is one article led by Lori Weiner that just had some phenomenal implications for us to consider. And their goal was really to talk about the ways that the COVID pandemic has impacted end-of-life care and approach to bereavement care, specifically in the pediatric palliative care field. And so their background started with a discussion on the cumulative loss and isolation and uncertainty that has been confronted by both health workers and by patients during COVID-19. They discuss the worry of parents who care for seriously ill children and really are worried that in the context of visitor restrictions, am I even going to be able to be with my child? And beyond that, confronting the limited accessibility of cultural rituals, the restrictions on funerals, of really being able to celebrate one's life after death, the limited ability of health teams to really best support patients and families in a holistic fashion in the way that they are used to expressing themselves, used to engaging. And then they also talk about the dissonance for healthcare workers that they feel between having a need for community, having a need to establish communities of engagement and connection, but also very much needing safety for themselves and safety for their families. And so in their results, they ended up interviewing and surveying 207 pediatric palliative care team members from 80 cities in 39 states and in the DC area. You can see there was quite a regional variation within the sample and also a very substantial disciplinary variation: physicians, nurses, social workers, child life specialists, psychologists. And on this topic, to measure moral distress associated with care, they used open-ended questions that really gave opportunities for participants to describe differing types of distress. And some of their example questions were, can you tell us about an experience you've had related to COVID-19 that you feel will stay with you always? What is something you have learned since COVID-19 that will impact your palliative care practice going forward? What is something you wish you'd learned prior to the pandemic that might have impacted how you approached palliative care during COVID-19? And some of the responses were really fascinating. And I will say they identified in their analysis 3 types of moral distress. And I'm going to tell you about those and also read some example quotes. So the first type is moral constraint distress. So this is where one is feeling distress because they are constrained from doing what they think is ethically appropriate. And some of the quotes that stood out to me was a participant who said, "I'll never forget telling a mama that her child would die, while the child's dad looked helplessly on via FaceTime because he had not been allowed on campus due to COVID restrictions. It was heartbreaking." Having a mother crying and very upset about her dying infant and not being able to hug her, it will stick with me. I hated it. The second type of distress is moral observer distress. So observing potentially traumatic events, but institutional or public health constraints make it impossible for a different action to be taken. And some of the quotes that stand out here: a young mother facing the extubation of her toddler with only one other family member able to visit with her, and their priest performing a ritual from the hospital parking lot. the trauma inflicted upon siblings that were not able to visit their sibling as they died. How awful, awful, awful it is when a family is not whole, when only one parent can be with a child. How staggering the suffering for all family members. And finally, this concept of moral uncertainty distress, where one is feeling distressed because they are uncertain about whether they are doing the right thing. And the quote that stood out to me was, "I don't know if it's the larger grief and stress we're all facing, or the lack of my team members with me, or if people are making different choices than usual and deaths are clustering, or really what the root of it is." And so in my own work, I've wanted to try to fill some of the gaps in the literature and better understand the experience of palliative care clinicians that are working in the oncology context. And so I led a study this year that asked the question, how effective did you feel in meeting the psychosocial and spiritual needs of acute oncology inpatients using telehealth during the first COVID surge? And so as many of you know, last spring, New York was really a global hotspot for COVID between March and May. And our palliative care team over a 10-week span was moved to a virtual platform for all inpatient consultations. And so I wanted to, a lot of the literature was focused on triage and emergency management, pain and symptom management. And I wanted to know how inpatient consultants were actually using telehealth to focus on psychosocial and spiritual needs, right? This whole other domain of palliative care. So I ended up interviewing 11 clinicians across 6 disciplines. You can see them there. We had 1-hour interviews that were recorded over Zoom. We used a qualitative descriptive approach with a qualitative methods specialist to code the data. We're in the preliminary phase of that. So some of our initial themes were about telehealth barriers and positives, clinician emotional burden. So this had to do with grief, distress, resentments, the perception of limited self-efficacy, right? I was unable and ineffective to fulfill my role. The perceived value of palliative care, how that shifted once it went from an inpatient in-person consultation mechanism to something over a virtual telehealth platform. The impact on relationships with patients, with families, but also with other palliative care colleagues and inpatient oncology teams. The barriers and facilitators to coping and self-care, and ultimately recommendations for the future. So even though this was a snapshot in time, really in the setting where the infrastructure of our system was unable to best support these providers, I still believe that their recommendations for the future are really warranted as we may continue to confront crises and next phases of the pandemic in the future. And so I just want to share a few quotes from the data. So this was asking a nurse practitioner about how she was making it through the day. And she said, "I don't know what I was telling myself. I think I just told myself, this is the normal. You just have to make it work. This is what we're doing to keep everyone safe, and just figure out a way to make it work. You know, making multiple calls throughout the day to reassure myself that this is okay. Yeah, and you know, checking in with the team. I got peer support from the team to say this was okay. And that's how I kept going, but the cases still made you feel uncomfortable." Another physician, in talking about her perception of cases, said that there are just those moments in those particularly difficult cases where just the frustration sticks. You carry it with you, and those are the patients that I remember. Now, I'm sure I took care of a lot of happy patients that maybe weren't COVID positive, or maybe they were, but they were discharged. But of course, those are not the patients that I remember. And some of the colleagues also spoke about cases that really stand out and stick with them. And this was one such case from a nurse practitioner who said, "One of the cases that haunts me was a woman that was COVID positive. Her daughter was in the room. I called her daughter, and her daughter was really upset and crying. And I was asking, what's going on? And she was like, my mom isn't doing well. Something's different. And I said, just take a deep breath. Can you see if your mom is breathing? And her daughter paused and started freaking out because her mom wasn't breathing. Her mom had died. And so it's like, being at home and being on the phone with somebody who's just lost a loved one, and then telling that loved one, her daughter, to ring the call bell and have the nurse come in is so upsetting that I feel like I wasn't there to do my job. It was a lot of distress for me. And so, you know, as a palliative care provider, listening to these interviews and you know, also just addressing my own positionality in that research, I had personal and professional relationships with these team members. Many of them, these interviews took place about 6 months after that 10-week virtual time span that I was exploring. And many of them said that was the first opportunity they actually had to talk about their experiences, ultimately to debrief. And so their interviews really led me to think about this concept of total moral pain. And so in palliative care, we talk about the Cicely Saunders notion of total pain, right? The physical, psychological, social, and spiritual factors that really interact and inform each other and are so interconnected in the experience of suffering that our patients have. And yet what's happening in the current COVID context is so many of our oncology and palliative care nurses are experiencing a total burden of moral pain that is affecting them physically, psychologically, socially, and spiritually. And so Cinda Rushton, who's a bioethicist at Hopkins, really says that one of the goals here with having these types of dialogues is to try to figure out how to decipher the need for support way before people get to the point where they're so distressed that it's affecting them with these kinds of symptoms. And so one of the things that's been supportive is really to build moral resilience. And I have back and forth feelings about resilience, because I often feel like it becomes incumbent upon the nurse to foster the sense of resilience, when really it's up to our systems and our administrators to help foster environments where resilience is possible, right? Where the health workforce can lean into their experiences of, or rather have experiences of health and well-being more regularly. And so I did enjoy these recommendations though, because this is focused on moral resilience and not just plain old self-care resilience. So the first recommendation, and you can read more about this at the URL that's listed there on the website, but they say define or redefine your personal moral compass. And I thought this was fascinating because, you know, organizations do this, but how many of us have actually really defined our moral compass to really reflect on how we respond in difficult situations, how we feel about the complexities that we confront at work? Or do we just wait to confront those situations at work and then kind of stand there with egg on our face, right? So preparing ourselves with a clear understanding of our own moral compass. And then to move that to the next level of defining our personal code of ethics. So again, organizations have codes of ethics, nurses have codes of ethics. So what is our personal code of ethics that we feel a loyalty and a responsibility to upholding in our lives as human beings and in our profession as nurses? To work on self-awareness, and I think this is so important, to really reflect on and understand why we are morally distressed by certain situations. So very often moral distress can arise because we think as individuals something should happen that's not happening. Meanwhile, organizations may have rationales that we have committed ourselves to as to why things need to follow a certain trajectory. So just being self-aware of what triggers our moral distress and how we work with that in our dual loyalties to ourselves and also our services and institutions. To develop self-regulation, this is a big one, to just understand our triggers. What happens emotionally with us? Do we get short with people? Do we get angry? Do we say, can we go get a drink tonight? Nothing wrong with that, but the point being there, do we seek opportunities to numb out when we get distressed rather than dealing with, processing, debriefing about what's really happening, right? Do we numb out with food? Do we numb out with exercise, right? There can be healthy numbing influencers as well. And then seeking outside assistance when needed, right? Asking for help, which I can tell you that I have not historically been good at, but during the COVID pandemic year, I have really had to build a capacity for. I have had to ask for help when I need it. And a part of that is doing away with the shame of needing help and being okay with asking for the support that we need, whether it's through individual one-on-one support through therapy or group support mechanisms. Earlier last year, I joined with Dr. Betty Farrell and a few other colleagues in medicine and psychology and law, and we wrote a small letter for Journal of Palliative Medicine where we really talked about COVID-19 as an opportunity to advance transdisciplinary models of care. And I do see this as one of the solutions moving forward to alleviate moral distress. And so, you know, when we think of palliative care, we have traditionally done interdisciplinary care well, but not necessarily transdisciplinary. So just to give you an analogy that helps me to understand the difference. So when we think of multidisciplinary, you can think of a bunch of pieces of fruit that you bought from the market and they're just kind of sitting in their whole form, apples, pears, oranges in a bowl. Multidisciplinary. When you think of interdisciplinary, you've taken that fruit out of the bowl, you've cut up the pieces of fruit. They're now in a bowl. The juices are kind of melding. You can taste a little orange on the apple. They're really complementing each other in a fruit salad. And then transdisciplinary, we take that fruit salad and we put it into a blender and we blend it up. And so the flavors, the cells, the characteristics of those fruit are really kind of completely intermingling. And so when we think about transdisciplinary models in palliative care, it requires having transparent dialogue about how people feel about transdisciplinary models, right? Especially how people who are really connected to their power and hierarchies are going to feel about that. To revisit how fellows are trained, how students are trained, to unify our frameworks, to make sure that every fellow that comes in, whether it's a nurse fellow, a physician fellow, a social work fellow, a chaplaincy fellow, all has rotations with all disciplines, is coming from a unified framework that is essentially a palliative care framework. And then to really address and redesign the research agenda to reflect on how science needs to change, how care needs to change, right? And the power of transdisciplinary palliative care and transdisciplinary oncology care is really about uplifting and amplifying the voice of those disciplinary partners who are so frequently overlooked, whether it's nurses or social workers, et cetera. But doing this and restructuring care to take on this transdisciplinary approach really requires moral courage, right? It requires being able to stand in our truth, to know what we think is best for our systems and services, and being able to really support that with the best available evidence. And I think a key component of whether it's moving towards transdisciplinary care or healing from moral injury is acknowledging that we've been traumatized in the COVID context in particular. Joshua Mance is a veteran who speaks a lot about moral injury, and this is a quote from his TED Talk. You can Google Joshua Mance TED Talk. And he says, "There's one central truth that has never changed and that I truly believe never will, that the only force of nature powerful enough to overcome the moral injuries that are inherent to traumatic experiences is a strong sense of community and human connection." And I really love that quote because it just emphasizes the need for all of us to share our stories in safe spaces without judgment, and providing the same level of compassion for ourselves and each other as we would hope that others would do for us. And so just taking a breath for a moment, I'm going to read another poem by Mary Oliver. And this poem is relevant to me in this conversation of moral injury because I think that once we start delving beneath the veil, once we start having conversations about our trauma, about our collective moral injury, I think we're going to see more and more of it. It may even feel insurmountable at first, right? Especially when we think of grief and the mass bereavement that so many nurses and so much of society is experiencing right now. So the poem is called The Moths. There's a kind of white moth, I don't know what kind, that glimmers by mid-May in the forest, just as the pink moccasin flowers are rising. If you notice anything, it leads you to notice more and more. And anyway, I was so full of energy. I was always running around looking at this and that. If I stopped, the pain was unbearable. If I stopped and thought, maybe the world can't be saved, the pain was unbearable. And I think so much of our call right now in nursing and in palliative care and in oncology is to be with that unbearable pain and build new muscles, new neural pathways to be able to talk about it, to be able to acknowledge that it's there. And I think that there is a way to get us from where we are, which is very often overlooking that level of pain, that level of distress, and really closing the gap to get to a place of where we want to be, which is really a health system where we can effectively alleviate the suffering of patients and families, but also alleviate the suffering of our colleagues, of ourselves, and also prevent future suffering and promote well-being. And so one of the ways I think we can do this is start to really advocate more and more for the integration of palliative care into all serious illness care as a human right. So this is an editorial I wrote with Dr. Farrell and Dr. Mason for JAMA a few months ago, where we really emphasize this point. And the idea here is that as we integrate palliative care into all serious illness care, we have the potential to decrease emergencies, ethical crises. We have a chance to build relationship and rapport further upstream in the disease process so that we can really, really lean on relationship-based care models. And we say in this editorial that every patient treated with a ventilator also needs palliative care. It is not an either-or clinical proposition, but rather a both-and moral imperative. Access to palliative care is a human right. Our inability to deliver it in the setting of COVID-19 and other serious illnesses is a human rights violation. Each of us is a stakeholder. And so I think in our settings and our systems, we need to go back to this model that so many of us have used for so many years, this integration model, right? Where we have treatment on the y-axis and disease trajectory on the x-axis. And we need to explain to people, whether we're talking about clinical practice delivery, whether we're talking about education for nurses in oncology settings, or whether we're talking about the research agenda, that this is how it really needs to go, that starting at the time of diagnosis, disease-modifying treatments work in conjunction with supportive and palliative care. Disease-modifying treatment options may decrease over time as the role of supportive and palliative care increases. But again, that synergy is connected throughout the trajectory of illness. And that palliative care teams can then become even more important also as hospice teams enter the relationship in the late stage disease period, right? To help with legacy building, to help with anticipatory grief, to help continue to clarify goals and values and preferences up to and including the time of death and into the bereavement phase. Right? So anybody who doesn't understand this is really missing the goal of palliative care. And so as we continue to advocate for fully integrative palliative care models, we alleviate the distress of that nurse who's going to be trying to provide bedside support to that patient who is dying and just seeing the palliative care team for the first time. And a part of this is the education we deliver for primary palliative care, right? Primary skills in symptom management and managing ethical complexities and empathic communication. So several of us on the LNEC team wrote this article for the Clinical Journal of Oncology Nursing, where we really went across all 8 domains of palliative care and broke down assessment questions and approaches for every nurse to use in delivering primary palliative care. And we said that to ensure person-centered oncology care throughout the COVID pandemic, it's imperative to provide this level of nursing education, right? So that what we're seeing, there is some evidence to show that as healthcare workers are equipped with these primary level skills, effective communication strategies, it actually can decrease their burnout and distress over time because they feel more equipped and empowered to handle challenging situations. And so if you haven't already, I'm sure you have, I want to point you to the LNEC site, specifically the page on support for nurses during COVID-19. And so this is just chock full of information. You'll see a number of symptom management infographics that can really support primary palliative care education. The infographics are with all different types of pain symptoms, delirium symptoms, also in people with anxiety and dyspnea. So if you haven't seen these, I highly suggest them. And then, of course, we also have a webinar on how we can support each other with loss, grief, and bereavement. And we've created an infographic and recently published an article in the Journal of Hospice and Palliative Nursing about how we can use the nurse coaching process to support bereaved staff. And this is something that you can do as a colleague. This is something you can do as a nurse administrator or leader for your staff. And I just want to break down some key components of the process. So the first thing we talk about is really establishing the relationship with your staff and identifying their readiness for change and support. So in this scenario, let me step back a second. You as, whether it's a colleague or a leader, are really serving as a coach to help support your staff through this bereavement process that so many people are going through as they've been increasingly exposed to loss and death. And so the relationship with your staff is going to evolve. You almost need to reestablish the relationship to be able to speak as human beings and drop all of the pretext of professional relationship in a sense, to ensure confidentiality and safety, to demonstrate the same therapeutic presence you would for a patient or another client, and to release these fixed ideas of where we think staff should be. One of the fears I have most is that people, and by people I mean health system leadership, are really going to expect nurses and healthcare workers to kind of get on with it. And there is no rule book for this. We've never done this before. There is no, the staff should be here with their healing, with their mental health. So releasing those fixed notions and taking the time to find out where they really are, to create a safe and healing environment. We all know how to do this as nurses. And then to set the ground rules, emphasizing, again, confidentiality, silencing phones where possible. You can even have like a phone basket where people can place their phones and gather them at the end of the session so that they can be fully available and present. You can use a talking stick so that only the person with the stick actually speaks so they can be fully expressive. And the job of the rest of the people in the room, if it's a group debrief, is simply to listen actively, not to give advice, not to fix, not to change, just to be available and present. Then the next step is to identify opportunities, issues, and concerns. So in the article and the infographic, we provide a series of open-ended questions. Again, doing away with assumptions of what we think we know about nurses' experiences. Just what is the biggest challenge you're having at work right now? The answers might surprise you. What brings you joy in your work, right? Not only emphasizing the challenges, but also emphasizing and exploring what motivates them. Asking them how they've dealt with recurrent loss during COVID-19, et cetera. And then to establish staff-centered goals. So help them identify SMART goals for their own well-being, identify strategies to achieve those goals. And also, the reality is that some of them may have been so embedded in clinical care that they may not be aware of all of the resources that are actually available to them, whether it's through your hospital or your clinical setting or your academic setting. So really help direct them as possible to the resources that may support further healing and processing. And then go on to create the structure of the coaching interaction. So really facilitating open exploration, alternative approaches, and assist staff to create action plans as appropriate. Empower them, motivate them. This is not going to be a one and done. I think in many ways, this is going to be a lifelong process, right? How do we really co-create cultures of self-reflection, of awareness, of supportive team environments, right? People are going to need support for a very long time. So we really need an all hands on deck, all in this together kind of mindset. And finally, assisting staff to determine the extent to which their goals were achieved. So as you continue to build this relationship, really promote their autonomy in identifying and then meeting their needs, and continue to be flexible and open and non-judgmental. I think that's really important, just open and non-judgmental. And of course, really, really embodying as much as possible the backbone of communication, which for me is empathy, right? Starting with their agenda, tracking what's happening cognitively, what the words they're saying, but also what's happening emotionally, right? We all know the experience of having somebody saying, I'm fine, but meanwhile they say I'm fine, but they're crying. So address the tears, acknowledge how they may be protecting themselves non-verbally, right? Use your nursing intuition. Really stay with staff, moving one step at a time. Don't move the conversation ahead too quickly. Articulate the empathy explicitly, right? Tell people that you have empathy for the situation that's actually happening. Talk about what you can do before you talk about what you cannot do. Big one. Starting with big picture goals and processes before we get to the nitty-gritty, right? Allow people to stay in that big picture space and talk about their overall experience. And then give them your undivided and complete attention. So important. Everybody knows when we're checking a box. Everybody knows when we're being authentically available. And so the last thing I want to talk about, the last tool we can use, I think, to mitigate our distress and really promote palliative care access at the same time is to educate ourselves about advocacy and about palliative care advocacy in particular. So I've been working on several palliative care advocacy initiatives, and I will say that it really does just overall help me to feel like I'm part of the solution. It helps me feel like I have a voice and that I can amplify that voice. to the people who are decision makers, right? So this word advocacy, sorry, and I just want to mention that we obviously advocate at the individual level, at the institutional and systems level, but also there's advocacy at a global level. So I'm going to touch base on all of those briefly in these final few moments. And so this word advocacy and the verb to advocate is derived from the Latin root voc, which is related to the word speech. And this really implies speaking for others. But as nurses, we know we're not really speaking for others as much as we are amplifying the voices of those who are not being heard, not being welcomed at the decision-making table. And so really our role as an advocate is to serve as this microphone that highlights our needs as nurses, the needs of our colleagues, and the needs of the societies that we serve. And I've had the good fortune, as I said, to participate in lots of advocacy initiatives. So last year, I was one of 127 palliative care experts from 24 countries who contributed to the Palliative Care COVID-19 series, these briefing notes that were led by these 4 major global palliative care organizations in providing recommendations to ministries of health, to governments, and to non-governmental organizations to provide palliative care in the context of COVID-19. And I contributed to 2 of those notes. One focused on inclusive palliative care practices for LGBTQ identified persons, and also another for persons experiencing homelessness during COVID. And then I went on to build continued relationships with the International Association for Hospice and Palliative Care and became their advocacy focal point for the United States. And so the main task of that role is to really hold our government accountable for supporting policies at a global level that encourage universal access to palliative care. And so I was a part of their delegation to the WHO Executive Board meeting back in January. And this was such a huge lesson in advocacy for me. And this is what I mean about feeling empowered. So a part of my job and the role is to build relationships with the US Department of Health and Human Services here at home. And I was able to work with the director of the Office of Global Affairs and his staff going into this executive board meeting. And one of our main asks was that the resolution that was focused on the highest attainable standard of health for persons with disabilities was undergoing a vote by all member states. And yet, when we looked at the definition of health, palliative care was not included as a component of this highest attainable standard of health. And through our advocacy work, through our data, our stories, our relationship building, we were able to work with the US government, who in turn worked with Israel and several other stakeholders, and we were successful in integrating palliative care right here in the resolution that was voted through. So the final resolution considers palliative care as an integral component of universal palliative care access for persons with disabilities. So, you know, for me, advocacy is about translating our desire and our hope to make a difference into really measurable outcomes. And finally, I just want to point you to this article in the Journal of Palliative Medicine that I wrote with several stakeholders from CAPC and also, again, the International Association for Hospice and Palliative Care. And we provide the top 10 tips. These are really advocacy experts. I just had the very good privilege of working on this article with them and learning from them in the process. But the top 10 tips that palliative clinicians should know about evidence-based advocacy. And I think that these tips are certainly applicable across domains of nursing, across the oncology setting as well. I'll just share a few of them with you really quickly before we get into a Q&A. So first, recognizing that your voice as a palliative specialist is so critical, and to use the skills you already know. So the backbone of palliative care is empathic, effective, evidence-based communication that is person-centered and really aimed at rapport building and trust building. So this kind of communication is critical in the advocacy arena. It's critical for building relationships with multidisciplinary partners, with economists, with policymakers, with decision makers at all levels. So trust that that skill set is something that you will use again and again. The second tip is to use a consensus-based definition of palliative care and to really stand together in that. One of the biggest challenges in people accessing high-quality palliative care is that people consistently misunderstand it, right? Even though patients with cancer consistently need palliative care, even in the oncology setting, it's the oncology clinicians that often misunderstand palliative care the most, right? It's overly associated with end-of-life care or the actively dying patient. And so we really encourage you to look at these consensus-based definitions, whether it's from CAPC or the National Practice Guidelines. If you're speaking to a global audience, you can use the International Association for Hospice and Palliative Care definition, which was a globally consensus-based definition. But it's important that we use consistent language when we're describing what we can and cannot provide as palliative care nurses. Third, be ready to explain the value of palliative care. So we talk about really helping people to understand that palliative care is one of the few disciplines that has actually shown outcomes that alleviate the suffering of patients and families, that mitigate caregiver burden, that improve symptom experiences and quality of life, that enhance treatment decision-making for patients and families. So be prepared to have that data in your back pocket, along with the stories that you see firsthand in your clinical practice, right? Data plus stories make us memorable. That's the backbone of advocacy. Advocating for palliative care as a component of the right to health. I love this, right? Really going with that idea, not even idea, that truth, making sure we're communicating that truth, that palliative care access is a human right, and that the inability to deliver it is a human rights violation. And so in the article, we provide lots of references and resolutions from the World Health Organization, from other organizations, the Lancet Commission on Global Access to Palliative Care, that really supports this truth that palliative care access is a human right. And so that's how we need to speak about it. And finally, to know the data that demonstrates that publicly provided palliative care can address social injustice and remedy health inequities. So having some of that data in your back pocket, and we give several examples in the article, so I'll kind of just leave you to read that at your convenience. But again, having a clear, empirically based understanding of how palliative care contributes to some of the biggest social agenda items in our country is really going to move us forward. And so I want to leave you with a quote that actually Dr. Betty Farrell shared with me very early in the pandemic and has become a daily meditation for me in lots of different ways. And I hope it does inspire you. It's from Dr. Clarissa Pinkola Estes, who is a psychoanalyst. And this is from her letter to a young activist. And she says, in any dark time, there is a tendency to veer toward fainting over how much is wrong or unmended in the world. Do not focus on that. We are needed. That is all we can know. One of the most calming and powerful actions you can take to intervene in a stormy world is to stand up and show your soul. Soul on deck shines like gold in dark times. When a great ship is in harbor and moored, it is safe. There can be no doubt. But that is not what great ships are built for. And so I think we have about 10 minutes left. I'm going to stop sharing.